It's Sarah here from BJC Health, coming to you from Sydney, Australia. Thanks for showing an interest in one of our educational events. You're about to watch part one, so enjoy the event. If you've got any questions about the content, then please consider joining BJC Connect, where you can access all of our facilitators live. Otherwise, please consider leaving a comment and we'll do our best to get back to you. Good evening, everyone. Hello. So big welcome to everyone. My name's Sarah. I'll just be in the background tonight facilitating. But thanks for joining us for tonight's event. And it's special for a couple of reasons. So one is I'll introduce you to our first, our main presenters tonight. And one is Dr. Herman Lau. So Herman, do you want to give everyone a wave? He's one of our presenters, and also Monica, who a lot of you know. So Monica, do you want to give everyone a wave? She's our dietitian, also very experienced. And yeah, looking forward to tonight's, tricky topic. So talking about inflammatory bowel disease and spondyloarthritis. So, but without further ado, again, welcome everyone, and I'll hand over to you, Herman.
Thank you, Sarah. I'm going to talk about spondyloarthritis and inflammatory bowel disease. And first of all, I'm a rheumatologist. I'm not a gastroenterologist, but I know a little bit about inflammatory bowel disease. And I'll go through some of the management. If you want to know a bit more about diagnosis, I'll talk about that as well. So spondyloarthritis, okay, there we go. Now, we'll start with the term spondyloarthritis. Spondylo means spine, arthritis means joint inflammation. And that's it, spine and joint inflammation. It is one of the group of conditions that's extremely confusing to understand. And bottom line is it can cause spine inflammation, along with it, a bit of joint inflammation and tendon inflammation and other inflammation in other parts of your body. This slide doesn't move well. There we go. So historically, there are 4 conditions in that family. The one that you see most talked about on the internet is ankylosing spondylitis. Then we have psoriatic arthritis. In particular, if you have spine involvement, it can be classified under spondyloarthritis. So psoriasis is a skin condition when you get rashes on different parts of your body. That's scary. And 30% of patients with psoriasis get psoriatic arthritis. And some of them will get spinal inflammation. Now, inflammatory bowel disease, there are 2 of them that generally classified under this umbrella. One is Crohn's disease, and the other one is ulcerative colitis. And many patients get a bit of joint inflammation, tendon inflammation, or spine inflammation with it. Then when that happens, you can classify the condition under spondyloarthritis. Or you can also call it enteropathic arthritis. So doctors are quite creative with terminology. Sometimes we use different names to describe the same thing so that we look smart. Now, lastly, reactive arthritis is a condition when you catch an infection either in the urine or in the bowel with certain bacteria, and your body responds by making antibodies. Unfortunately, that results in joint inflammation, tendon inflammation, or spine inflammation. Then there are patients who don't fit in the big 4s. Then we give them some names called undifferentiated spondyloarthritis when they get their spine inflammation, but no other features like psoriasis or bowel inflammation, and no evidence of infection. And lately, there's a new condition or entity we call non-radiographic spondyloarthritis. A mouthful to call, but I'll briefly talk about that in a minute. Okay, doesn't advance well. I'll try again. There we go. All right. So the core manifestations for these conditions, you can think of it as axial manifestations when you get predominantly spine inflammation. Then the peripheral manifestations, so you can get joint inflammation. Enthesitis is probably not a term many of you have heard about. It refers to inflammation at the junction where the tendon or ligament attaches to the bone. So we call that enthesitis. Then patients can get what we call non-articular manifestations, in particular skin, then you get psoriasis. When you get inflammation in the bowel, you get inflammatory bowel disease. Or more commonly, if you get inflammation in the eyes, we call it iritis or uveitis. And that's the iris, the color bit of your eye, that's the iris, it gets inflamed. Okay, now a very interesting slide to show you the different conditions and how they can present slightly differently. If I point your attention to psoriatic arthritis, when you get skin psoriasis, the rash, you can get a fair bit of peripheral manifestation, and a handful of patients will get spine inflammation. Whereas the radiographic axial spondyloarthritis, the proper name for that is ankylosing spondylitis, you predominantly get axial manifestation. Yeah, you can get a bit of spine peripheral inflammation as well. And for patients with inflammatory bowel disease or reactive arthritis, they sit in the middle, meaning that they get a bit of everything. Let's talk about spine inflammation. All right. Now, patients present with inflammatory back pain. Now, spine inflammation, the inflammation is caused by your immune system going the wrong direction, driving the inflammation. So it's different to the inflammation you get from osteoarthritis or spraining your back muscle. Those are mechanical or degenerative type inflammation. So autoimmune inflammation, the characteristic is quite distinct. Patients present with inflammatory back pain, usually starts in the sacroiliac joints. Now, sacroiliac joints is really at the bottom, is behind the gluteus maximus muscle, your bum muscles, at that level. So when you point to your lumbar spine, it's usually the back, but sacroiliac joint is lower. The hallmark of the inflammatory back pain is pain worse in the morning. Sometimes it wakes a person up in the morning. Person may come in and describe, well, I wake up at 4 a.m. or 5 a.m. in the morning by the pain. And there's usually a lot of stiffness associated with the pain. And the pain improves with exercise. So very unlike osteoarthritis or other muscular causes of back pain, it improves a lot with exercise. Now, another hallmark of inflammatory back pain is it responds really well to anti-inflammatories. So patients will come in and say, whoa, I took Voltaren the night before, the next morning, I woke up, I felt fantastic. I took meloxicam or Celebrex, it works really, really well. Whereas patients with osteoarthritis type back pain or myofascial pain related to poor posture, when they take anti-inflammatory tablets, yeah, it helps a bit. Yeah, it's all right. It's okay. That kind of response is quite different. Inflammation usually starts in the sacroiliac joints, but in some patients, it can involve the lumbar spine or the thoracic spine or even the neck, in particular in patients with ankylosing spondylitis. In early stage of the disease, you can't see anything on X-ray. You really need an MRI scan. So one of the common story I hear from my patients is, oh, I've had this back pain that wakes me up in the morning. I've had multiple X-rays and CT scans, but doctors told me that it's all normal. What's going on? Because you can't see inflammation on CT scan or X-ray, in particular in early stages before any bone changes. You really need an MRI scan to look for it. And when you do an MRI scan of your back for inflammatory back pain, you need the MRI scan of your lumbar spine and also the sacroiliac joints. And that's the trick that some doctors, when they haven't seen patients with spondyloarthritis or ankylosing spondylitis, when they order MRI scan, they forget the sacroiliac joints. By the time you see X-ray changes, it means the inflammation's been around for a fair while. We're talking about 5 years or 10 years. So there you go. Let's move on. Now, so that's a picture of an MRI scan of the sacroiliac joint. So we've got the sacrum, the bottom part, that's the ilium, and that's the sacroiliac joint. In this sequence, healthy bones should be dark gray like this, whereas whiteness shows inflammation. Oh, what happened there? It went back. There we go. So when the bone is inflamed, it will look white on this sequence, and that's what we look for in patients with sacroiliitis or inflammation of the spine. Now, X-ray of the same structure, the sacroiliac joint, we've got the sacrum and the ilium. All right, so we've got the joint. On the left side is healthy sacroiliac joint. You see the the lining of the bone very clearly. You see the gap in between, right? You see that that's very clear. On the right side, it looks very different. You can't see the gap between the bones. It looks almost like the bones are fused. Perhaps you can see a little bit here, right? And the cortex is quite irregular and fluffy and burry. And that's a sign of long-standing sacroiliac joint inflammation, sacroiliitis. By the time the person has X-ray changes, the inflammation's been around for a long time, 5 years or 10 years. Okay, now let's move on to talk about peripheral inflammation, peripheral manifestations. So peripheral joint inflammation, meaning that the joint can become inflamed. Any joints can be affected. Now I've got some pictures I downloaded from the internet. Got a knee. See, obviously this knee is very large and inflamed. Sarah took a good look just then. I could see very big swollen knee, and usually feels really warm, and it's obviously painful to walk on. This is an ankle, very, very inflamed ankle. Then look at his hand. He's got a finger that swells like a sausage, right? And the Latin term for that is dactylitis, sausage finger. And that's a hallmark of a kind of peripheral manifestation of psoriatic arthritis, which is one of the conditions under spondyloarthritis. Likewise for the toe, you've got a big red hot inflamed toe. That's another dactylitis. It's very painful. And this patient, you can see the nails, the toenails. That one looked pretty healthy, but the second one and the big toe looks thickened and white and didn't look very healthy. And that's another finding of patients with psoriatic arthritis. We call that psoriatic nails. The nails are thickened and they can get crumbly. So peripheral joint inflammation, any joint can be inflamed. You can get it in your jaw, you can get it in your wrist, in your fingers, any joint. Enthesitis. Now that's the very interesting thing that people started paying attention to in the last 5 years, 7 years, because we now understand enthesitis a lot more. And that may actually account for a lot of unusual aches and pains the patient presents with. Now, we have a picture of a bone, and that's a bit of a tendon or a ligament. That junction is called enthesis. And we get inflamed, we get put an itis at the end, enthesitis. Okay, so that's enthesitis, and the most common places we get it is where the Achilles tendon inserts into the bone at the back of the heel. We call it Achilles tendonitis, but strictly speaking, it should be called Achilles enthesitis, because when you talk about Achilles tendonitis, some of you may have attended Team Lee's talk, tendon team. We talked about Achilles tendon in the past. It refers to a higher level where the tendon meets the muscles. So if you talk to your doctor saying, I've got Achilles enthesitis, they will say, whoa, you know about your body really well. Achilles enthesitis. Plantar fasciitis is when a person presents with, keep saying that, heel pain right at the bottom of the heel. Now, if the inflammation is there long enough, you get a bone spur, and a lot of patients will talk about, I've got a spur, bone spur pain. Is the spur giving me pain? No, actually, if you have a spur in the heel, the spur goes horizontally along the tendon, along the plantar fascia. That's because the tendon, plantar fascia has been inflamed for a long time. There's a lot of blood flow. The bone grows along that little bit of tendon. So that's why the spur is horizontal. So if you have an X-ray of your heel with heel spur pain, pick it up, have a look, you'll find the spur goes horizontal. And that doesn't give you pain. It's actually the inflamed tendon that gives you pain. Now, heel spurs are very common. Plantar fasciitis is very common. Most patients, it's caused by a mechanical issue. Abnormal ankle and foot posture, abnormal shoes, altered biomechanics. But in patients with spondyloarthritis, they can get heel spur pain or plantar fasciitis unprovoked, unrelated to walking. They can wake up in the morning with it. It can last for weeks and weeks and weeks and weeks. And even if they see a podiatrist, have orthotics organized, It's still present. It doesn't get better. It comes and goes. It comes and goes. It can go on for a long time. You can get enthesitis in other parts of your body. So that's a little diagram to summarize where you can get it. You can get it in the lumbar spine between the bones. You can get it over the pelvis, the edge of the pelvis, the bony bit, where all the ligaments and tendons stick onto the pelvis. You can get it around the knee. You can get it around the elbow, where the big muscle sticks onto the bone. When that happens on the outside of the elbow, we call that tennis elbow. When you get it on the inside, we call it golfer's elbow. But it's not a mechanical cause of tennis elbow or golfer's elbow. It's an autoimmune cause. So you get it in a lot of places. Another common place I find in my patients is in the ribs. They describe, weeks of unusual rib pain and tenderness. It's painful to breathe and painful to turn. Of course, we have to rule out whether the person has posture problem, where they sit in front of a computer screen, the screen is off the side, they have to work twisted. So we have to exclude mechanical causes at the same time. But these are the common places people can get enthesitis. So there we go. That's a picture showing Achilles tendon on the left side. That's healthy. On the right side, see that's swollen, right? At the junction, that's enthesitis. Let's move on to talk about non-articular, meaning non-joint related manifestations. So psoriasis, you may have seen patients with psoriasis. It commonly occurs over the extensor surfaces like the elbow or the knees. It can be anywhere. It can be along the hairline, can be at the back of your neck. It's a plaque with scaly skin. But it also comes in different forms. It can be what we call guttate psoriasis, like little dots. It can be all different forms. Sometimes rheumatologists and even GPs, they have trouble confirming the diagnosis of psoriasis, and we need the help of a dermatologist to confirm the diagnosis. The nails is another big thing. In patients with psoriasis, they can get involvement of the nails, and that's quite typical for psoriasis or psoriatic arthritis. The nail is thickened, it's crumbly, it can peel. It does look a little bit like fungal infection. But the story will be the person's GP has treated it as fungal infection with ointment and even tablets for weeks and no improvement. And now you look at the rash, psoriasis, there we go, psoriatic arthritis and psoriatic nails. The eye, look, the most common manifestation in the eye is uveitis, so-called iritis. So it's extremely painful and red. So if you have a bit of itchy eye, little watery eye, that's not uveitis. Uveitis is very painful. Patients can't open their eyes. Usually they go straight to the GP or emergency department, and they get an eye doctor involved and say, yes, it's inflamed. Now, if you look at this eye here, not only the sclera, the white bit is inflamed, you see the cornea, the white bit in the middle. See how it's quite cloudy? The whole thing looks smoky and cloudy. That's because it's full of inflammatory cells inside the chamber. And at the bottom here, see that white bit? It's actually pus inside the anterior chamber. So it's highly inflamed eye. You need steroid eye drops, you need systemic steroid. Otherwise, you can have long-term damage to the iris. Okay, now let's talk about inflammatory bowel disease. I've been asked to talk about inflammatory bowel disease, although I'm not a bowel doctor. Now, there are two diseases in this family, Crohn's disease and colitis. You can think of them as sisters. So for Crohn's disease, the involvement is the large bowel in a patchy, segmented fashion. So it's not continuous, patchy. It can affect the small bowel as well. Whereas ulcerative colitis affects just the large bowel, the colon. That's why we call it colitis, the colon. The symptoms, they're quite similar. So patients present with a loss of appetite, may have blood in the stool, fatigue, fever. You can get ulcers in the mouth. tummy cramps, tummy ache, weight loss, and diarrhea. Sometimes you pass mucus in your stool as well. Now, bit of schematic representation of the bowel lining. That's the normal colon, smooth and quite pink. Ulcerative colitis is highly inflamed, it's red, you can get ulcers. And with Crohn's disease, the inflammation, it goes all the way down to the bowel wall. So it forms little bubbles, little polyps. If any of you are eating dinner now, I suggest you look away because a confronting picture will come. All right, now that's a real picture. On the left side, colitis. See, that's inflamed and red with a little white patchy bit, that's ulcers. And that's Crohn's disease. See this cobblestone appearance. That's the hallmark we teach our medical students. What gives cobblestone appearance in the small bowel? They need to know that it's Crohn's. So if you have if a gastroenterologist put a camera down the stomach to look at the small bowel, or colonoscopy to look at the large bowel, that's what they will find. I'll move on then to talk about treatment for inflammatory bowel disease a little bit. Pretend to be a gastroenterologist. For acute flare-up, when things are highly inflamed and painful, the person has a lot of tummy pain, passing blood or mucus. First thing is bowel rest. So they may actually need to go into a hospital. They have IV fluid to keep them well hydrated with all the minerals. Then the doctor will give them steroid, either prednisone tablet or IV, to really knock the inflammation down. And the dose of steroid is much higher than the dose we use in inflammatory arthritis. We're talking about 50 or 70 milligram, or even methylprednisone, big doses. Once the acute inflammation settles, then we go on to maintenance therapy. Then we use what we call disease-modifying drugs or immunosuppressant, and there are quite a few of them. You'll be surprised to hear that we use the same medicines to control rheumatoid arthritis or other form of inflammatory arthritis. Of course, some are more specific for the bowel, but many of them we share common. We use the same medicine. If the person has ulcerative colitis and the involvement is mostly in the lower half, the distal half, sometimes the doctor will use enema medications to treat internally. If all fails, then we use biological agent. And again, that's where rheumatologists and gastroenterologists bond. We talk about which drug is good for your bowel condition, which drug is good for your joints, and you try to find a common drug that works for both. Some of them works better for the bowel, some of them works better for the joint. So we have to talk. Now, diet. I'll leave that to Monica. Monica, I'll hand over to you to talk about diet in inflammatory bowel disease.
Thank you, Herman. So if anybody here has inflammatory bowel disease, or what we talk to patients about with that inflammatory bowel disease, is once you're in maintenance phase. So these are the recommendations, not if you're in hospital or undergoing that steroid treatment or the bowel rest that Herman was talking about. So if somebody is having a lot of symptoms like stomach pain, diarrhea, nausea, any of those types of symptoms, then we definitely recommend that they keep track of their food and that they record all their symptoms so that we can try and work out what the triggers are. For most people, it helps to eat smaller meals more frequently than having larger meals. And for a lot of people with inflammatory bowel disease, it doesn't necessarily work to do fasting or intermittent fasting. We like to encourage to base meals on anti-inflammatory foods. So just like we talk about the Mediterranean style of eating, and we talk a lot about anti-inflammatory foods for arthritis, it can be helpful in inflammatory bowel disease as well. So basing foods on fruit and vegetables and plant proteins. If you're eating animal proteins, then we want those to be lean, take the saturated fat out of them, include things like legumes, nuts, seeds, and fish. Now, of course, as a dietitian, we like to make these things very tailored personally to each individual person. And some people won't be able to have the legumes and won't be able to have a lot of nuts and seeds, depending on how they manage fiber. So we really want high fiber when you don't have a flare, and very low fiber during a flare. And if you're having bowel rest, but not necessarily, if you're still allowed to eat, we keep the fiber really low. Once the acute inflammation has been managed, then we slowly want to bring the fiber back up again to moderate amounts up to high amounts. But this is a very individual need for each patient, and we work with everybody to see what they're like with any bloating, if they have any loose stools or diarrhea, and then we help people even calculate how much fiber that they're having so that they understand how their bowel works. A lot of our clients might consider a trial of probiotics and things like garlic, ginger, turmeric. All of these things have some good evidence for inflammatory bowel disease. The research is not all the highest form of research that we would talk about, but there is good evidence that these things may help some people. We need to stay hydrated, so it's really important to drink adequate water. People might also choose to have herbal teas and even green tea, which is anti-inflammatory. And I like to encourage all of my patients to make sure they're talking with their GP, their gastroenterologist, if it's part of also a joint condition and they're seeing a rheumatologist, to make sure that their vitamin and minerals are adequate and they don't have any deficiencies, because then it's really important to focus on foods that give them the vitamins that they need if they are deficient, and if needed, then we go for some supplements as well.
So you've just finished watching part 1 of one of our recent educational events. Hope you enjoyed the content. If you'd like to access part 2, then you need to sign up for BJC Connect. It's a free platform where you can access not just the recordings of past events, but also access a whole range of upcoming future events and access our team of facilitators live. All of the details that you need to join BJC Connect are now flashing up on your screen. Otherwise, like our staff, subscribe if you'd like to see more information from BJC Health. Look forward to seeing you in an event soon.